So the end product of the study is basically a step-by-step approach for clinicians about how to involve patients using motivational interviewing, how to involve them in antidepressant therapy. And this approach we find could be useful for almost anybody. The project on the use of motivational interviewing in medication treatment for depression is designed to address a major problem that exists with respect to antidepressant treatment, which is that patients from all racial and ethnic groups have difficulty engaging with medication treatment. Many are very ready to take the medicines, but a lot of people have ambivalence about whether it's the right treatment or not. And it happens that underserved racial and ethnic groups, particularly the research is strong with Hispanic and African American groups, have a higher rate of non-retention. That is to say, they stop treatment early, and also a higher rate of non-adherence. That is to say, they don't take the medicines as prescribed, even higher than those rates for other racial and ethnic groups. So we wanted to address that with a new way of delivering antidepressant treatment that tackled some of the barriers that underserved groups face in terms of taking medication treatment. There are many barriers to why people would have trouble taking their medicines. Some are very sort of easy to understand in terms of, for example, finances. Medicines can be expensive. In terms of not being sure whether that's the right treatment or there's a different kind of treatment. There's also questions about whether there are people who speak the language of the patients. There are a number of reasons. People may not have insurance, all sorts of reasons why it's hard to stick with a treatment that it goes on for a long time, like treatment for depression. However, there are certain issues that come up with the treatment with medications, particularly with certain populations. It happens with a lot of different kinds of people, but there are certain populations where it comes up a lot that we would understand as a form of ambivalence, where on the one hand, they think it's really important to take the medicines, they're concerned about the depression, it's really affecting their lives, they really want to do something about it, and on the other hand, they're not sure that medicine is good for them, it might cause all sorts of problems, it might be addictive, it might, not be right for them as a treatment. And because of this decision balance that they have to make, this leaning one way, leaning another, we felt that that could be related, and some data had shown that would be related to doubt and concern about taking antidepressant treatment for a period of time. And so we wanted to have a therapy, a way of approaching giving the medication that dealt with, helped the patient resolve that ambivalence. Because of the research that showed that ambivalence was involved in people not sticking with the medicine treatment for a period of time, for a length of time, then we looked for a psychotherapy that could be helpful in resolving ambivalence. And motivational interviewing was designed precisely to help clients figure out what they wanted to do. It comes out of a substance abuse treatment origin, and the notion is to help people who are having trouble with, say, alcohol decide whether they should or should not stop drinking. And so in this way, motivational interviewing became a perfect platform around which to help us discuss ambivalence about taking or not taking medicine with the patients. So because we had chosen motivational interviewing as the platform around which to discuss taking or not taking medicines, we needed to change motivational interviewing in a couple of ways to work for our needs. One way that we needed to adapt, if you will, motivational interviewing was to the taking of medication. Mostly, MI, as it's known, had been used to help people make other behavior changes, like not drinking or doing other kinds of activities in terms of changing their behavior. But there had been not much work done on helping patients resolve ambivalence about medicines. And so we had to adapt motivational interviewing to the taking of medication as the behavior that we wanted to speak with the patient about. And in addition, we had to make sure that MI tackled the concerns that particular populations had with respect to taking medication. And in particular, we were working with a Latino population. So we needed to understand the reasons that people felt why they were ambivalent. That involved stigma, specific fears about how medicines may be harmful to people, particular barriers that come up in terms of chronic care, like making it to appointments. People have multiple obligations, so we had to involve steps to help patients feel motivation to continue with the treatment and overcome a series of rather difficult obstacles in their path. So we had to adapt it. Another reason for the adaptation was that many patients, including many underserved groups, expect the doctors to be authoritative and tell them what to do. And MI is not designed like that. It's a much more collaborative process. So we had to make sure that the patients and the clinicians were on the same boat in terms of what each one's role was, in terms of what's the proper role for the doctor, the proper role for the patient, and yet give each one a role that was equally important, even if it was somewhat different. And so all those adaptations had to be done in order to have MI inform antidepressant treatments with Hispanic patients. So what we've done in terms of this project of enhancing engagement, we call it, of patients in antidepressant therapy, what we've done is develop a new way of doing antidepressant therapy from the point of view of the doctor, so that it's much more eliciting of the patient's concerns and ideas about whether to take and not to take the medicine. And then instead of like telling them what to do, you actually motivate the patient to come up with their own solutions and their own ideas about what it is they need to do, so that they feel much more engaged in the decision and in taking. For example, we'd like them to try the medicine, and so we try to encourage them to find a way to take it. But if they decide not to take it, that's fine. Also, we're able to, they need to make a decision one way or the other. They need to resolve the ambivalence, whether it's in favor of medicine or in favor of a different kind of approach. It could be that they decide to go do a psychotherapy. That's fine too. So the end product of the study is basically a step-by-step approach for clinicians about how to involve patients using motivational interviewing, how to involve them in antidepressant therapy. And this approach, we find, could be useful for almost anybody, but it's possible, and that's one of the things we're studying now, it's possible that it's particularly useful for people, for example, who may not have had exposure to antidepressant therapy before, or maybe more concerned. It's possible that they already know what's coming. Involving them in questioning it a fair amount might actually create questions where none exist. And so one of the things that we're really interested in now is figuring out which groups is it particularly useful for, so that we can guide clinicians into picking the right approach for the right patient. So having developed this new way of conducting medication treatment for depression, we now are interested in making sure it gets used in the real world, and in figuring out the best ways to actually train people in how to do it, and also in the best ways of implementing this in a real world clinic. And so if you're interested in that, and we'd like to hear from you, your ideas about how this might be done, you can contact us. And also if you want to find out how to conduct this form of treatment, we have the manual for the treatment that we call Motivational Pharmacotherapy. We have the manual for it in the initiative section. In the section under engagement, there's a section on the motivational pharmacotherapy approach.